For those of you who are at home, welcome. We're a few minutes early. So we're not going to kick off till 1 because, for obvious reasons, if you miss the first 5 minutes, it's going to be like missing the first few minutes of an Agatha Christie. We're going to do that right now, Brian. I was going to do that. It's a good interruption, Brian.
He's just checking.
It's a good interruption. Shilpa, would you like to go first? Would you like to introduce yourself?
I'm Shilpa Gupta, medical oncologist at the Cleveland Clinic. Really honored to be here.
Carla, far away.
Sure. So Carla Sridhar, medical oncologist, Princess Margaret Cancer Center. Also super happy to be here.
Andrea.
Andrea Apolo, medical oncologist in Bethesda, Maryland, at an unnamed institute.
Great to see you all. Petros Grivas, I'm a medical oncologist in Seattle, University of Washington and Fred Hutch Cancer Center. This is my third in a row Uromigos meeting, and I'm very excited about it. Great to be here.
That was my introduction slide. Okay, so I'm going to talk a little bit. We're not going to have very many slides. We've got maybe half a dozen slides, maybe a few more. I've made them myself. They're mainly accurate, I think. I've tried very hard, but some of them were quite difficult. We're going to start by talking about Niagara, and then we're going to move on from Niagara. We're going to talk about adjuvant trials. We're then going to talk about other neoadjuvant trials. And then from there, we're going to talk about, we've got a couple of votes. Oh, we didn't talk about that. There are some votes coming up, and I think it's with a QR code. So you take the picture of the QR code, you then vote, then that will come up. The voting in this section, I think, is towards the end, about 3/4 of the way through. And then at the end, we're going to talk about bladder sparing approaches. And we're also going to talk about what might happen if the ADCs have positive trials in this space. So the Niagara trial was a study which we explored the combination of durvalumab with Gem/Cis in the neoadjuvant space. But we also had the adjuvant period as well, 8 adjuvant cycles, making a total of a year of durvalumab therapy. We compared it to 4 cycles of Gem/Cis, standard treatment. We allowed split-dose Gem/Cis, and a significant proportion of patients did get split-dose. That allowed us to go down to a creatinine clearance of 40 rather than the traditional 60. The primary analysis was 1,000 patients. It was the ITT population. The study itself was run globally over 200 sites around the world. It started enrolling before nivolumab was approved, so it didn't have nivolumab as part of the control arm, and that's almost no patients had adjuvant nivolumab in the study. More contemporary trials, I think, will be different from that. It allowed different histological subtypes, providing there was a component of urothelial cancer. Obviously, patients needed to be fit for radical cystectomy. One of the surprising things from my perspective about this trial was the large proportion of patients who went on to get radical cystectomy. It was an open label trial, and about 85% of patients in both arms had radical cystectomy. Indeed, a few more patients in the durvalumab arm had cystectomy than in the study arm. And there's debate about why that might be the case. Petros, in his discussion, talked more about the detail of these surgical patients. The data set's relatively immature. We haven't been through all of the detail, but I can tell you, and it was in the New England Journal paper, that the commonest reason for not having cystectomy was patient choice, and then behind there was doctor's choice. I wonder, with hindsight, if we need to write our CRFs more clearly in the future. I'm not sure our CRFs are always fantastic. And that also applies to subsequent therapies, not just in this studies, but in other trials as well. I think when patients come off study, we tend to be much more lax about the detail that we report. But when we do report it, everyone thinks it's a randomized phase 3 and that data must be golden and absolutely correct. And so I think that even with the context of a randomized phase 3, some of the data we use can be improved. I actually think that also applies to adverse events. At the session in ESMO this year, the discussant for the breast cancer plenary session described CTC criteria for chemotherapy. And if you look at this trial as well, there's no real difference in adverse events between the two arms, but we all know that immune therapy is associated with life-changing toxicity. And we haven't really got our head around how to measure life-changing toxicity, and indeed, we haven't got our head around measuring quality of life. In the maintenance of avelumab trial, there was no difference in quality of life between the two groups. But we all know that coming to hospital every 2 weeks and having an injection with a 10% chance of life-changing toxicity does have an effect on quality of life. So within the context of this trial, some of the data points, in all the trials we do, some of the data points are really accurate and very robust. Others we need to put in the context of what we know. The study itself had two co-primary endpoints. The first was pathological complete response. Pathological complete response read out 6 months initially after the primary analysis. And that showed a difference between the two arms that wasn't statistically significant. That was because a very low amount of alpha was allocated. But also 59 patients weren't allocated correctly because the analysis was done prematurely. And that was a programming issue. And actually the analysis here is the correct analysis for all of the patients. I'm going to talk a lot about PathCR today. And I've spent a lot of time on this issue over the last 2 or 3 days. And I've read maybe 20 different studies looking at PathCR. And I can tell you it's extremely confusing. People report PathCR very differently. Some people use only the surgical patients, some use all the ITT patients. Some studies are broadcast prematurely, where not everyone's got to have the opportunity to have the surgery. And in other studies, radiotherapy was given as an option, and some people in those studies use clinical CR as PathCR also. It's also true that some people think TIS, in situ cancer, is PathCR. We did that in Abacus, by the way. And other people don't accept that as PathCR. So I really warn with caution when we start doing PathCR cross-trial comparisons. The final piece is there's huge variability in the T2, the clinical T2 stage. One of the things that we forget is in the adjuvant setting, we have the pathology in the pot, and we know what the T and the end stage is accurately. In the neoadjuvant setting, we try and combine CT radiology with pathology to come up with a clinical stage, and I don't think that's particularly accurate, to be honest. So again, we're comparing T3, T4 with T2. I'm not sure that's particularly accurate. But here, these are the most robust analysis we have. It's the ITT population. Everyone was included. It's a 1,000-patient study, and it was centrally assessed. And this is probably the reality of GemCis and GemCis durvalumab, and I suspect this becomes a new benchmark, although we as a group can have that debate in a second. Event-free survival is different from disease-free survival. Disease-free survival is assessed in the adjuvant setting. In the neoadjuvant setting, we count surgery as an event. And that brings its own level of complexity, because patients don't have surgery for different reasons. And indeed, some of the winners don't have surgery. And I'm quite worried about the EV-Pembro and EV-Durva-Tremi trials. There was a SURE trial recently, neoadjuvant sacituzumab govitecan, where the last 7 patients in a row opted for radiotherapy rather than surgery. Now, strictly speaking, they're going to be in the ITT population, and that means they're going to have a low PathCR rate. We as a group need to have a discussion about how we're going to assess that.
So Tom, if I could interrupt you, I don't think it's
That was a nice
just pathologic. It's not just pathologic response rate. Event-free survival, disease-free survival also vary within trials. And we saw that in the Ambassador trial versus the Checkmate 274 study, in that the definition was not exactly the same. So we actually had a workshop that we got together with the FDA, and we talked about this because there was so many variable differences as to what you count as an event. Do you count a TA coming back in the bladder in somebody that had an upper tract disease as an event, or do you just kind of scrape it out and not count it as an event? So that's just one example, but there's variabilities in general, not just in pathologic complete response rate, which is huge. And I think there needs to be a consensus in order for us to design the best trials with comparable outcomes, but also in disease-free survival and event-free survival, which right now they're not.
Andrea, if you have local relapse, and I think the BCL 2000, in the adjuvant setting, how does the FDA think we should account for?
So this was an interesting point because there was a panel, there was the FDA, and we discussed what local relapse would count. So if it was a muscle invasive local relapse, yes, of course, then that is considered an event. If it was something that could be managed with a TURBT, with a scraping, with or without BCG, then that may or may not be counted as an event. And the panel was split. And of course, we were an even number. So, so we basically just wrote it up as saying you may or may not, but you have to define that in the beginning and you have to let people know what you're counting. And for the ambassador study, we did not count local recurrences that could be scraped out as events, which is different than the Checkmate 274. And you may say that that's not right, and some people say that that makes sense because it's not a metastatic recurrence and you can treat it locally, but I think it's up for debate. So I just think that we just need to have a consensus.
I'm going to keep going with that. So event-free survival was statistically significant, and so was overall survival. You can see the absolute differences there. There was a phase 2 study in purple here. This is one of my slides. You can see that. I've got a series of slides. And the phase 2 study out of Switzerland is actually the only other perioperative study. Most of the other neoadjuvant trials we've done have been purely neoadjuvant. Doing investigator-initiated perioperative studies is much harder than doing investigator-initiated neoadjuvant studies because you've got to give them the patients that adjuvant period of therapy as well. So it's a lot more expensive, and for universities it's more difficult. But the Swiss did do that, and actually they show quite similar results, as you can see here. So Shilpa, Petros, you did the discussion, so you're going to go last. Shilpa, what do you think about the results of Niagara, and what are the strengths and what are the weaknesses? And then, Carla, I'm going to ask you after that about what you think we need to do next and what we haven't seen so far.
Yeah, I think congratulations on the Niagara trial to everybody who conducted it. I think it's a phase 3 level 1 evidence, large trial, 1,000-patient trial, clearly shows overall survival, event-free survival benefit of Gemcis Durva. I especially like the fact that it was more inclusive than a lot of other trials, that N1 patients were included. Creatinine clearance was in the traditional Galsky criteria, but what we really use in the real world, 40 was the cutoff instead of 60. So I think all those were really great to see. And I think it also points out to the fact that PCR is not the ultimate endpoint, and we have to see the durability of the response and the overall survival. And we've never seen such data before. So I think it also highlights that patients who got downstaging to T1 or lower also derive benefit. With the advent of immunotherapy in this space, we need to move away from just PCR because of the nuances you mentioned and look at what the event-free survival and the overall survival is. I think the only weakness I would say is that we have not really teased out the neoadjuvant versus adjuvant portion of these immunotherapies, and FDA is now mandating us to think about that, just like in lung cancer trials. And for example, if somebody gets PT0 with neoadjuvant treatment of Durva Gemcis, do we really need to continue adjuvant, and for how long? I think those are the questions we need to answer.
And if they don't respond,
do
you continue adjuvant treatment in somebody who didn't respond
so
at all?
We really need a trial like the melanoma folks have done, where we are looking at adjuvant versus neoadjuvant portions.
I agree with Shilpa. I love how forward-thinking this was and that it included a lower GFR. I really like that with the split dose. It's something that we do in practice. It's really nice to have a trial here. It would be important to know how those patients did. So that's really important. And in the N1 disease, I was a little confused as why there was only 5% of the patients that had N1 disease.
We amended the protocol. We allowed them in
figured,
towards the end, number one. And number two is it was surprising. We amended quite early, and I was expecting there to be many more patients. And I don't know how you feel when you're looking at radiology with patients and they've got nodal disease. I think many surgeons now are a bit anxious about putting them through a big operation. We kind of are here. Petros, what's your thought on that?
First of all, I agree with all the points made, and I think to your point, it's very difficult sometimes in the ECRF to capture accurately N0 version 1. We have these scenarios,
like
these
a
gray
fuzzy
zones,
node that you're not really
fuzzy
sure
nodes
what
that
it
Andrea
is,
mentions,
right.
which is like 9 millimeters or 10 millimeters. We don't bother to biopsy sometimes because we start with neoadjuvant chemotherapy and see what happens. So I am wondering whether this 5% may be actually be higher. We just didn't capture it. But I
think
agree.
the cutoff was 2 centimeters, right?
How was that defined, Tom, the N1? Because other trials define it, not the RECIST measurable, but like 1.5.
1.5,
1.5
right.
or-
I think this was 2.
There was
yeah.
a 2 centimeter
Yeah.
limit with that. Yeah.
Which,
Probably that's why you did it.
Shortest axis, yeah.
exactly, as Andrea points out, the short axis, some people use 1.5 centimeters in the short axis, and I'm sure that many people did not get a biopsy, which is not the routine practice for all.
Right.
So you might potentially have had a higher proportion. But I think overall in clinical practice, we tend to approach the N1, the single perivesical node patients, usually similar to M0. So I liked that I saw that in the Niagara trial. The other point, if I can just comment too, I was very happy to see that divergent histology. I know you have an interest, Andrea, with ICONIC trial, were included, and I think it was 15%, Tom. About half of them were squamous histologies, and the other was a mix. It was good to see that, and if I remember correctly, it was not mandatory to have predominance of urothelial, as long as you have a primary urothelial histology.
Carla, what was your take when you saw this? Firstly, do you think it's practice changing? Do you think it's broadly practice changing? And then what are the concerns? What do you still need to see from this data set that we haven't seen so far?
Yeah, so I echo the congratulations. I think it's the first trial in the neoadjuvant setting. I think it shows that we can actually do trials in this setting. And, fortunately it was a positive trial, which always adds to the enthusiasm and excitement. So I think I was really happy about that. All the points that were mentioned, I like the fact that it allowed a creatinine clearance that was a bit lower, split dose, which of course is something that we've done a lot of and looked at. And I think it's so much easier for our patients. It's a nice way to give platinum-based chemotherapy. I like that. In terms of node-positive disease, I think this is defining itself almost as its own entity. Like it's sort of not quite MIBC, not quite metastatic disease. So I love the fact that we're including it because it's practical. Admittedly, you may not be picking up all the node positivity with CT scans, right? Because they're very dependent on size. There may be normal-sized lymph nodes that actually might have tumor cells within it. So I think all in all, I like the study. I like the fact we got it done. I think the results are encouraging and interesting. A lot of questions remain unanswered, and I think we'll answer that over time. One of the areas that I'm particularly interested in, what about the patients who didn't get surgery? Did they get bladder sparing? Did they get trimodality therapy? And what are their long-term outcomes? We have seen propensity analyses showing that patients who get radical cystectomy and trimodality therapy who are appropriately selected have similar outcomes. Sometimes even TMT does a little better. What's happening in that patient population? And you mentioned the SURE study earlier. Patients who have a complete response don't necessarily want to lose their bladder. And I think we need to listen to that. And we need to think about designing trials like this, but are somewhat agnostic or open-minded to what happens locally. Because often we're in a situation where you get this really great neoadjuvant regimen, maybe something like EV Pembro, but then you're mandating a cystectomy, and is that really appropriate or patient-friendly?
Andrea, I wanted to come to you next. You led the ambassador study. This is a slide which I made at home last night. As you can see, it's not perfect by any stretch. In fact, I couldn't find your grade 3 or 4 treatment-related adverse events, which I know are there somewhere, but I couldn't find those. I apologize. I've summarized there a series of adjuvant trials that are ongoing. The first is obviously the NEVO 274 study, approved in all comers here in the US, only in PD-L1 positive patients in Europe. I put the OS signal up there, presented at the EAU by Matt Galsky, not statistically significant, but potentially clinically meaningful. And below there, I've got the Atezo ctDNA data. We're going to talk about ctDNA, so don't feel the need to go into the detail of that right now. But you can see here the 24-month disease-free survival rates, actually quite low, most patients relapsing from a disease-free survival perspective, in your study too. And then I put down that's the meta-analysis from GemCis of the adjuvant chemotherapy. What's your take on adjuvant therapy today and how it fits in with the context of the Niagara study?
Yeah, so a lot to talk about. I think that adjuvant therapy is active. Running the trial, I saw it firsthand, and then when I finally analyzed the data, it was shockingly positive, and I say shockingly because we had the withdrawals when nivolumab was approved, and patients in the observation arm going to nivolumab. So it really confounded the outcomes. I don't know if we're going to be able to interpret the overall survival data, but it really is active. So do I think chemotherapy is active? Of course I do. I also think that chemotherapy is active, and if the patient did not receive cisplatin-based chemotherapy, I think they should. I think all these agents are active. I mean, when I saw the Checkmate 901 data in the metastatic setting, gemcitabine being more active, it was modestly more active than just chemotherapy, I knew these trials were going to be positive. Because this is almost the same setting. I mean, you can argue that muscle-invasive disease is not metastatic disease, but you can argue that it is. So I'm not surprised that the Niagara study was positive. I'm really happy that it was with durvalumab because there's been a lot of concerns about the PD-L1s versus the PD-1s. And I always said they're all active. You know, I know that it really depends a lot on trial design, patient selection, but I think honestly, I think all the checkpoints are active. I think it's the question you ask and how do you design a trial. So anyway, I'm really happy that the Niagara study was positive. I'm not shocked that it's positive, and I expect the rest of them to be positive too.
Petros, I want you to expand on Andrea's point. I agree with what she said. I don't think, we talked about adjuvant therapy being this sort of, or patients think of it, their cancer disappearing and suddenly coming back by some miracle. But that's not the case. They've just got minimal residual disease. We just haven't been able to spot it on an X-ray. And the reality is in bladder cancer, because it grows fast, it's just a matter of time. And that's why disease-free survival in this setting is so short. Maintenance avelumab has some parallels to adjuvant immune therapy, and 901 has some parallels to Niagara. Could you expand on that for me?
Great discussion. I agree with the points made by my colleagues and friends here. So I think, number one, as everybody mentioned, it was a huge effort to complete the more than 1,000 patient trial in the peri-operative setting in the context of prior trials that had difficulty accruing. At the time the trial was designed, it was very difficult, of course, to predict the future, to be able to tease apart neoadjuvant or adjuvant or both. So the big question that your question implies is, do we need both? Or the adjuvant is carrying the weight of the benefit? A couple of thoughts on that. So number one, what do we know so far? We have the maintenance avelumab data in metastatic disease that shows overall survival and PFS benefit. So there is some value, I think, added, in my opinion, by the continuation of, in this setting, adjuvant checkpoint inhibition.
But to who? Right, we don't know that.
That's a great question. We don't know to whom, because...
Is what you're saying that if it's 4 months of neoadjuvant at the moment, it's too short for you?
So far, based on what we know and based on the trials, it's hard for me to exclude that adjuvant is not needed in some patients. I agree with Andrea, we need to know that.
Let's talk about what you said in your discussion, because in your discussion you said you wanted more detail of the PathCR patients.
Absolutely.
And in the prior discussion, in the prior presentation, the breast cancer group did present that PathCR data.
Correct.
Do you want to describe the data that you're looking for and maybe just talk a tiny bit about how ctDNA might be able to help too?
And I want to see it too.
Absolutely. So part of my wish list to Tom and the study team in my presidential symposium discussion was, can you give us an ad hoc exploratory analysis of how patients did disease-free survival, overall survival, stratified by the pathologic states, the accurate pathologic states, pathologic complete response, defined as YPT0 and 0, pathologic downstaging, YPT less than YPT2 and 0, and pathologic residual muscle-invasive disease. I would love to see that in the Niagara trial and the subsequent trials. You are correct, Tom. We saw this snippet of data in the breast cancer Keynote 522 trial, exactly before the Niagara. And to me, it was interesting because with long follow-up in that breast cancer trial, there's still uncertainty if the subset of patients with PathCR still benefit with the adjuvant pembro or not. I think the hazard ratio was 0.69 in the breast cancer trial for the PathCR patients with a very wide confidence interval crossed 1. So I think that data will be very useful to see at Niagara. I know you will follow up the patient and see how these people do, because the critical question is exactly that. Do you need to treat everybody? We're going to over-treat patients.
But to piggyback on your maintenance analogy, you are giving maintenance to the responders, right?
That's
to
a
the
great point.
chemotherapy responders. So you would argue by that argument that they don't need it, but I guess we don't know, right?
Exactly.
And we saw in Javelin that PR/CR stable disease all benefited from the maintenance. So you might see that coming out as well. those who get a PCR may equally benefit, right?
You can argue either way. I think you're right. We do not really know. Is it 4-dose neoadjuvant enough? Is it enough to have the long-term survival benefit? Or you need that almost a year duration of treatment? And I don't think we're there yet to know. Would love to see data from Niagara based on the past stage. Would love to see data from other ongoing trials, KEYNOTE-B15, the GemCis plus minus Pembro, GemCis plus minus Nivo. I think the other nuance point here is, if you think about the Nadina trial in melanoma, that they did neoadjuvant versus adjuvant, neoadjuvant appeared better.
But that was Ipi-Nivo.
It was Ipi-Nivo, different treatment.
In melanoma. And that's very different from durvalumab chemotherapy in bladder cancer.
Of course.
And we spent a lot of time trying to repeat what we did in melanoma in bladder cancer, and I got really burnt when I did that.
Different tumor type, different treatment.
Let's agree. Okay.
Tom, I had a question.
Yes.
How many patients in the control arm got subsequent immunotherapy at any point? Is that data available?
So the data is coming out with that. It's actually a very low number at the moment. And in both arms, subsequent therapy in all of these trials is lower than I would expect. There is some robust data from Checkmate 274 suggesting about 66% of patients go on and get subsequent therapy after adjuvant therapy. That feels very low to me.
But we don't know how accurate that is, right? That doesn't mean they didn't receive it. That's just what was documented.
And then this has got really low data too. But you think, so some people say, look, hold on a second, these trials were done in countries where there was no access to X, Y, and Z, and therefore, they should have all...
That's probably true too.
Partly, but everyone's got access to platinum-based chemotherapy. Yeah. And so therefore, in the adjuvant trials, you would expect 90% of patients to get frontline metastatic treatment, and it's only 66%. And so this is one of the issues around clinical trials. We think randomized phase 3 studies are all truth, nothing but the truth, but actually it's only as good as the quality of the data we're collecting. And I'm concerned about subsequent therapies. We are going to present more around that, but the numbers are low, as we've seen in the other adjuvant trials.
And I think this was part of my wish list too, my last bullet point. Can we do our best, and you're doing your best, to capture subsequent therapies, adjuvant and metastatic, because this can have impact in the survival endpoint. The last quick comment, Tom, you asked about ctDNA. I think as we get data from all these trials, including the tombo that we saw, we'll talk about the stratification at the cystectomy phase to inform our decision.
We're coming to it. Petros, one more shortcoming. So we talked about lots of strengths of this trial, but one more shortcoming that you put on your list that we haven't discussed so far. Anything that you think we haven't discussed around this trial that we should highlight to the group?
I think I agree with all the points. One thing that I think is worth discussing is a dose-dense MVAC chemotherapy.
Can we come to that now?
Okay, great. Wow. Perfect.
Okay, here we go. So again, this was on the aeroplane on the way here with PubMed.
That sounds early, very early for you.
This is very early in the morning. This is a summary of the peri-operative trial. So going down Atezo, that's obviously Abacus, then Pembro is Pure 1, TAR 200 is Sunrise 4, MVAC is the SWOG study, and then below that is dose-dense MVAC as part of the VESPER trial, GemCis Nivo, the largest single-arm chemotherapy neoadjuvant trial, then EV, SG, and DV toripalimab. There are some blanks there, and if you go onto PubMed, you'll see some of the data is different. So I've recalculated the PathCRs using the denominator where I can. Sometimes I've not been able to do that. So this is the best I can do.
Right, because there were different definitions.
Everyone's got different definitions.
And different eligibility for a lot of these trials.
And different eligibility, which I put CT2 in there. So this study this is not supposed to be a direct comparison of where we are. This is just where we are, and you can make of it what you will. I probably should have a big caution, say, don't make direct comparisons. But my interpretation of this slide at the moment is that in the MVAC study, the SWOG study, 40% of patients had T2 disease. CT2 is blank there, it's supposed to be 40%. That's what this Niagara study was benchmarked off. And that's why we have 40%, and that's why we capped at 40%. We wanted to try and reproduce that large trial. You can see here T2 being very variable. And you can also see the PathCR rates being pretty variable, and I can see being non-comparable. And the 24 months event-free survival, being, again, very dependent on the patient population. Petros, what do you make of dose-dense MVAC? Well, no, Shilpa, let's ask you a question. What do you make of dose-dense MVAC? And do you think that, and how does dose-to-MVAC fit into the Niagara study? And Carla, same question to you afterwards.
So I don't really use dose-dense MVAC. You know, if you look at the data across US, only about 30% patients get any neoadjuvant cisplatin-based therapy. So I think we have to do better at offering cisplatin and not be kind of married to just dose-dense MVAC. It is a more toxic regimen. Unless I have a very young patient, I don't. In the Vesper, they use 6 cycles of dose-dense MVAC. It's really not practical for us to expect in the community that, you know, we should be going and preaching that give dose-dense MVAC. I think we have to preach give cisplatin, no matter how, split dose or regular dose. So in my practice, I use only 10% of dose-dense MVAC, if at all. I'm very comfortable with GemCis and GemCis IO.
Carl, what's your take on this rather chaotic slide and how you have got to a position where you're treating patients in Toronto?
Yeah, I mean, I like your chaotic slide. It thinks it puts somewhat in perspective,
data, yeah.
But and the variability and the sort of lack of harmonization is quite evident. But I mean, for me, I tend to agree with Shilpa. I use a lot of GemCis. I do use split dose, so I'm very happy to see it in the Niagara trial as well. Even in that setting, I rescan after 2 cycles just to make sure they're not having disease progression. I think it's about giving platinum-based chemotherapy, ideally cisplatin, whatever you do to do it well. I think that's the message. I don't split hairs between GemCis and dose-dense MVAC, and I have concerns about 6 cycles of dose-dense MVAC as well. I think the one point I'll say here, I'm curious about the TAR-200, where you have a device within the bladder, of course, that's eluting gemcitabine. Is a PCR
Can we come to TAR-200 in 2 seconds?
Okay.
We've got a specific slide on that. Before we get there, I wanted to just talk about ctDNA, and Andrea, perhaps you'd like to take this on. So circulating tumor DNA is gathering momentum. I haven't showed the Tombola trial data here. I've shown the data from IMvigor 010 and 011, which essentially shows using the Natera technique, but there are other methods that we could use too. But using this personalized technique, you can identify 40% of patients who are ctDNA positive post-surgery, and those patients that are positive have about a 90% chance of relapsing compared to 30% of the negative. And this is the OS data. On the left-hand side, dark blue atezolizumab, dark red placebo or best supportive care, and you can see a benefit there. On the right-hand side is IMvigor 11. IMvigor 11 is trying to validate those findings. It may or may not be successful. It's completed its enrollment of over 200 patients. And on the right-hand side is just tracking those negative patients, and if you remain negative over a period of time, your chance of relapse is pretty small. Andrea, how is ctDNA going to change what we do moving forward? Does it currently have a role, yes or no? And what do you need to see to change your opinion on what's going to happen with it?
So it's available to us in the United States, and I don't like to get biomarkers that I don't know what to do with them because we don't have prospective trials, but it's hard for me to not get data if it's available, so we get it anyway. And then we're just kind of sitting around nervous for the patient because they're like positive and the scan is negative, and I sit around nervous, the patient sits around nervous, and this is kind of what we do. So I think this data is going to be so valuable as to tell us to be more aggressive with the patients. And what that is, we have to figure out what that means to be more aggressive. But I do think that we overtreat patients. And some patients don't get treatment, but patients that do get treatment, not all of them need it. And I think this is going to be a really important marker. I've been very impressed. There was a patient that was, for example, ctDNA negative, NED on the scan. We followed him. The ctDNA kept on going up. We're like, he doesn't have anything. This is driving us crazy. And then 6 months later, he's got carcinomatosis everywhere. And we were like, oh man, like, would we have done something different at that point? He had already gotten both neoadjuvant and adjuvant therapy. I don't know what we would have done differently for him, but just in general, I think it's very accurate. I think it's really important to incorporate it prospectively, and I think it's going to really help us enrich our trials in order to treat the patients that really need the treatment and observe the ones that don't.
Does ctDNA analysis have any role in the Niagara study? So at the moment, if you, let's say you are post-surgery, you're ctDNA negative.
Absolutely.
And what is that wrong?
I think we need to do it in order to see the patients that, how was the downstaging, how did it correlate with the ctDNA? We can learn more. And then the patients that went on to the adjuvant, how did they do? I think that's all going to be really valuable. I know it's retrospective, but it's going to be really valuable and informative for us.
What happens if IMvigor11 is positive? The validation study of the adjuvant setting showing that if you're ctDNA positive, you benefit from atezolizumab versus placebo. Do you think that would supersede adjuvant nivolumab in those patients that can't get neoadjuvant chemotherapy?
I think that it's important information, and a lot of people, when the IMvigor01 data came out, which is the adjuvant atezolizumab data, said, well, it's not an active drug. And I just think that it has a lot to do with trial design and what the endpoint was, and I think it is an active drug. I've used it in a metastatic setting, and I've seen some really nice responses. So I think it is going to be important. How does this fit in with nivolumab? I think these are all active drugs. I think it'll be another option. And we should really focus on treating patients that are ctDNA positive, I think, until we have other ways of assessing who really needs the treatment.
Carla, one of the issues is if you give neoadjuvant immune therapy, so in the adjuvant setting, I think it identifies patients who potentially are at risk, who potentially have MRD, and it's not perfect and it's not bad for that. The bit I like about it in the adjuvant setting is by the time you've got measurable bladder cancer, immune therapy, the horse has bolted as far as I can see, and that was the problem with Danube and the other trials, is if you give immune therapy to measurable bladder cancer, it just grows too fast, you never get control of the disease. MRD, if it's not yet measurable in that patient with a 6-month or 4-month lag period, the runway's longer to get control of the disease. And so I could see, had the neoadjuvant trials not been positive, this would have had a massive impact, because treating ctDNA negative patients with a relatively low risk of relapse may be a bit counterintuitive, providing these trials were positive. But in the neoadjuvant setting, when you've cleared your ctDNA, those are the winners. And you might say 3 months of therapy, if you're winning with immune therapy, the patient's going to come back and say, hold on a second, why are we stopping the drugs that were working? If they're ctDNA per surgery, do you think that's the conversation which patients will have? Or do you think they're going to say, oh great, I'm fine, I need to move on? The question I'm asking is, if you clear your ctDNA, is 4 months long enough from a patient perspective, or do we need to keep going for the whole year?
I mean, I think that patients tend to want treatment more than they don't want treatment. I mean, we've seen that in the maintenance story. And I think a subset may say, okay, I've cleared my ctDNA, I can be done. But I really think that there's a bit of a pressure to keep going with treatment. And I think we still need more data to understand what are the ctDNA dynamics. And, up front, does the addition for your Niagara trial, does the addition of immunotherapy to upfront platinum-based chemo, does it help you clear your ctDNA better? And I think that'll be an important question that maybe ctDNA data will help us.
So what I'm hearing from you three is the ctDNA data are actually, we don't have enough yet, we're using it.
We don't have enough data.
And we can't make any hard decisions based off it.
But we do.
But we do, but we can't. And none of you are prepared to say, I would do this definitely because of that. And it all ends up being, we need to see more data. So this is all premature. Shilpa, I wanted to move on with you and go through this. This is the toripalimab data, disitamab vedotin plus toripalimab. It was at ASCO. It was out of China. I highlighted it as the Annals of Oncology top kind of, buried gem out of ASCO. And the reason why is, now, there are lots of caveats with this. The trial's not...
MIBC, right?
This is muscle-invasive bladder cancer, but they've reported a 61% path-CR rate. When you go into the detail of the trial, it's quite complicated because it's really immature and they're only halfway through the study and they've reported that. And so there are a whole series of patients on study which haven't been reported yet. And so strictly speaking, you can divide that by 2 and bring it down to 30% if you obey the Niagara rules. But I think that's partly unfair because the trial's not finished. It's just immature. But Shilpa, if that 61% path-CR rate, what impact, because we've got trials coming up with EV Pembro, EV Durva-Tremi, if you've got a 61% path-CR rate with EV Pembro, EV Durva-Tremi, what's going to happen to the field?
I think what could happen to the field and what might happen to the field is that we may move away from radical surgeries or any radical treatment to the bladder if we are seeing some really great clinical complete responses with these novel combinations, and we can probably avoid any radical treatment.
So not doing cystectomy potentially in some patients who are having clinical complete response?
Correct.
We're going to come to that in a second. Tony, do you have a question?
I have more than one question, but it's going to be fast.
Far away,
Okay.
Tony.
First of all, I do like your socks. Red would be better, like I'm wearing. So there are 3 things you didn't address in Niagara trial, a study I do not like. I think history will show that Niagara potentially have done more damage to the field. Let me explain. The 2 things I would love you, maybe it's not completely in the paper, but future is what happened to the patient that didn't get cystectomy and the subsequent therapy for which we're going to address you and I in an editorial that's going to come soon. But the issue here with Niagara is that now we're married to durvalumab pre and post. It did not ask the question whether we need adjuvant therapy, yes or no. And potentially, drugs that are active in the adjuvant setting, maybe with a survival benefit, nivolumab, maybe pembrolizumab with more, won't be used anymore. We are married to one strategy.
Yeah. So let's just take that question first. So first, could we have done 3 or 4 arms in the trial? It would have been hard. It's a 1,000-patient study. The previous trial, the EORTC study that closed early with only 150 patients in each arm. So I think embarking on a 3-arm, 1,800-patient study at that time would have been difficult, number 1. I think number 2, the adjuvant setting is, while I think it may be associated with a survival benefit, we haven't yet seen that. We've done 3 studies without a significant survival benefit. So I think it'd be wrong to say we don't know that. We do know that the adjuvant setting doesn't yet have a survival benefit. And then the third issue, which I think is relevant, is one of the things that we've learned in urothelial cancer is that giving therapy up front with immune therapy, leaving your drugs, your best drugs, in the locker, particularly immune therapy, associated with long-term durable remission, is a mistake. Maintenance of avelumab is better than second-line therapy. Waiting for second-line therapy with pembrolizumab is, I think, a mistake. And giving these drugs earlier is the beginning, in my opinion, of not a mistake, but the beginning of a new chapter where we might end up not doing surgery at all, and we could even end up curing urothelial cancer. Now, don't get me wrong, these other neoadjuvant trials may come and report, and they may be negative, and we don't yet know. But Niagara could be the first star to appear in the universe associated with curing muscle-invasive bladder cancer. And under those circumstances, Tony, people would look back at your approach, which is surgery followed by adjuvant therapy, as being somewhat archaic, because not only are we curing more patients with a survival advantage, we're also not doing cystectomy, and that must be seen as progress.
I partially agree. I'm going to rebut 2, and I think this is important. 1 was the ctDNA, and I agree fully with Andrea and the study you're dealing. This could have been different. The second thing is you may not need adjuvant therapy. The ideal study would be neoadjuvant with cisplatinum base versus cisplatinum base plus immunotherapy. And after cystectomy, when you get the result of cystectomy, you give the adjuvant du jour, whether this is, gemcismore, gemcarbo, whatever you want, immunotherapy, whatever the adjuvant du jour. And in a large study, it doesn't need to be 3,000 patients, 800, 900 patients, you see what happened. And you answer forever the question of neoadjuvant. Niagara is good, but it stops midway.
But Tony, that's a cooperative group trial, right? That's an adaptive design cooperative group trial, right?
We work with a lot of industry. We could convince 1, we convinced 2 to do the immunotherapy re-challenge, Tom and I. So while you are right, but it's not impossible.
But I would also add that for the ctDNA, we have not seen any data from Checkmate 274, even though it's been so many years out. So at least we saw that data for the Invigor 010, and hopefully we'll see that for the Niagara at some point.
I have a quick question. The patients that did not undergo radical cystectomy in the Niagara, did they continue adjuvant?
So it's a mixed bag of those patients. And I think that the detail of those patients, I hope we're going to present at ASCO GU. We've looked at it. One of the really disappointing things about those patients is the commonest reason is patient choice. And I don't think that's, what is that choice? What does that conversation look like? Why don't they want cystectomy? What I think is intriguing is we will look back and try and correlate the PathCR results or the response results, if we can, some of the radiological response results with those patients, get real granularity about that decision. One of my concerns about EV Pembro is so active, we feel, that patients, I think, will say, hold on a second, I want to have a cystoscopy before I have surgery. And that's going to cause chaos in the trial, because if they have an event, and that counts as an event, the winners will be the losers in the trial, and that's going to create a very grey result. And in fact, if I was designing those trials tomorrow, I would just say go for OS. Don't worry about EFS, because you're going to have OS. You haven't got OS, you've got to beat Niagara. And so get OS and don't worry about this EFS, which, by the way, might not be working in your favor.
Or as Andrea pointed out before, rediscuss with FDA the definition of event-free survival. In that study, in the Niagara trial, it was about 6% in one group and about 7% in the other group that selected to not undergo radical cystectomy. And that may have impacted PathCR and potential, as you said, event-free survival, because they count as events. So I would love to see in my wish list what happens with those patients, as Andrea pointed out. And the question is, should we harmonization across those trials, should those count as events? Can we, of course, design future trials? To Tony's point, I think Niagara is a step in the right direction. It captured the idea that we need perioperative therapy. In the future, if we try to design a trial today, we can think about this cooperative group potential design with 3-4-arm trial, but 6-7 years ago, this sounded like a gigantic effort. So Niagara is in the right direction. I think there will be over-treatment. I think there may be under-treatment too. So until we define better biomarkers, ctDNA is the most promising. We need more work and more data. For now, we take the Niagara as a sandwich approach, but we definitely welcome more data from Niagara and the other ongoing trials to inform that adjuvant therapy decision in the future.
So two quick points. So one, I don't know if I completely agree with your comment about patient choice. I think the fact that patients are making these choices is real life. It's happening on the ground. And I think to have it reflected in a trial, I think is actually a good thing. That's the first point. The second point, I think we're in a little bit of a challenge right now when we think about bladder sparing or trimodality, whatever you want to say, because if you think you have patients who have neoadjuvant chemo, then they get cystectomy, then they have the opportunity for adjuvant IO. Now you compare that with patients who are getting bladder sparing, there is no adjuvant IO component to that. So the fact that some of your patients who didn't get surgery did get adjuvant IO, I think is important and will be important data for us. We've seen that even in Matt's trial where, again, patients who chose to not have their bladder taken out because they had a complete clinical response, again, they went on to get adjuvant IO as well. So it's trying to sort of, harmonize even between what we're doing with patients who have cystectomy, but also those who have bladder sparing, and I think that'll be important. So more and more, I think patients are choosing to keep their bladder. We need to reflect on that in our trials and in our practice.
Fabulous. This is the VOLGA trial. This is ctDNA analysis for durvalumab, tremelimumab, enfortumab vedotin. Only 17 patients, but very premature. But ctDNA analysis using a different technique. This isn't Natera. This is GRAIL, and you've got ctDNA clearance in 70% of those patients that were positive. I wouldn't overinterpret this, but your PathCR rate of toripalimab plus DV of 61% and your ctDNA clearance rate of 70% points towards the results of EV Pembro and EV Durva-Tremi being very positive. Now, whether they are or not, we'll have to wait and see, but I'm quite encouraged by that.
But comparing pathologic CR and ctDNA are completely different things, yes. Right? One is local, what's happening local, which may not be important for systemic disease versus systemic disease.
I prefer ctDNA analysis.
Me too.
Oh, you too? Okay, great. We've got somewhere. We agree on something on ctDNA. Carla, you wanted to talk about Sunrise 4.
Just one quick point.
Yeah, we'll get very quick.
That will be interesting to see Niagara and the other trials to see the concordance between PathCR and ctDNA. I may be wrong, but I predict that the majority of PathCR patients may have ctDNA negative, but would need to see that data to see that concordance and whether that.
But not always. And the reason not always is because it may not be systematically relevant disease.
That's the local and systemic.
Systemic.
Carla, you were keen to talk about Sunrise 4.
Yeah.
Sunrise 4, do you know about it? You're far away.
I know about it a little bit.
Yeah.
I mean, really it's looking at combining an immune checkpoint inhibitor and TAR-200, which is this cool kind of pretzel device that elutes gemcitabine locally. So this study really looked at TAR-200 plus citrilimab or citrilimab monotherapy. And I do notice a number of patients here were refusing neoadjuvant chemo. I think it's an important point to keep in mind. The point I was going to raise with this is, we talk a lot about pathological complete response rate. And does a pathological complete response rate with an agent that's giving gemcitabine locally, is that the same as a pathological complete response with someone who's getting neoadjuvant chemo? And I don't think we know the answer to that. And I'd be curious to know if ctDNA could play a role in trying to understand this a little bit better as well.
Does TAR-200 have any role in muscle-invasive bladder cancer if the neoadjuvant systemic therapies are mopping up the disease effectively, getting rid of the MRD? Does local control make any difference? Under what circumstance do you see Sunrise-4 and TAR-200 having a role to play in muscle-invasive bladder cancer?
I would say that in this, it's not just the local control. When you combine it with the checkpoint inhibitor, you are getting the systemic control too. And if as you can see here, 61% patients refused cisplatin, so I'm assuming they were cisplatin eligible, or I don't know, but that would be assumed. And if you're getting systemic control with immunotherapy, getting good control with TAR-200 and sparing them the toxicity of cisplatin-based systemic chemotherapy, I think that'll be big. But again, this is a smaller study. We'll need to see phase 3 study.
Petros, convinced me that TAR-200 in the future, even if these trials are positive, has a role to play in muscle-invasive bladder cancer.
It will be a hard one. The reason is because you mentioned the Volga trial and Keynote 905 in cisplatin-ineligible patients. We have to wait for the data, but the assumption is these are very likely to be positive trials. So the question is, how does this fit in the context of those two ongoing trials in cisplatin-ineligible patients? Will be a hard competition. I suppose patients who, number one, may be ineligible to get those drugs systemically, which is a very tiny proportion of patients, maybe less than 10%, might go with a local approach, or those patients who do not want to risk having systemic therapy, I think will be a hard competition in the context of Volga and Keynote 905. Although the drug is very active, as Kala mentioned, it's impressive, but I predict it might have a role soon in non-muscle invasive disease.
I have a comment. I think that it will play a role for bladder preservation trials because you've got great systemic therapy that we are moving into the perioperative space. And if we can control the disease in the bladder, then we're golden.
And these are the next generation of trials. To Tony's point, what Andrea mentioned, as we get better and better with systemic therapies, effective systemic therapies, pembrolizumab and enfortumab and others, Volga regimen, are we going to be in the point to cure more patients by introducing systemic therapy earlier at the stage of micrometastasis, Tom, that you alluded to? I think we're getting there. I think, Kala, you mentioned us before. The big question is, can we develop clinically useful biomarkers to identify, select those patients who have long-term remission with bladder intact? That's the future. We're getting there. We're not there yet, but we're getting there. The Hoosier trial by Matt Galsky was in that direction. The Retain trial is also in that direction. So I think we're getting there in the future. Maybe systemic therapy alone in selected patients with reliable biomarkers.
And I want to add, Tom, that they're not mutually exclusive. The EV Pembro, if it moves in that space, or the Volga regimen, and if after that we don't do cystectomy and we don't do radiation, just put TAR-200 in to control local control, I think that would be really the future gold standard.
Shilpa, which of these trials is going to be negative?
I first want to point out that the SWOG gap trial closed even right after it was open.
This was your slide. This was your slide,
I know,
isn't
but
it?
that is, I think, from 2 years ago. So,
Okay, Shilpa, which of these trials are going to be negative?
Will be negative?
Any of them? Or they all, is
I
Niagara...
think they're all going to be positive.
They're all going to be positive. Yeah.
I think the SWOG trial closed, if I remember.
Yes, it is. Shilpa said that, yeah.
Closed. I think the big question to me, Tom, I think all of them will be positive, but for EFS, the big question in my mind is, what about OS? And the question is because Adjuvant nivolumab got approved in August 2021 in the US.
Yep.
I think it was April 2022 in Europe. The question is, if the control arm of those trials, if they have exposure to Adjuvant nivo and potential more systemic therapies as salvage in metastatic disease, would that potentially wash out any survival benefit? would we have a potential risk of not having a positive
Well,
trial?
then those trials are going to be
because of that?
complicated because if the EFS analysis is complicated because patients are choosing not to have surgery and the OS analysis is complicated because of the control arm,
Right.
then you might say, actually, maybe they're not all going to be positive. Petros.
It's going to be a risk, especially because of the adjuvant and metastatic therapies and patient selection of avoiding cystectomy.
I'm going to go back one. I want you to tell me EV Pembro, let's keep it simple, EV Pembro, EV Durvalumab, what's the PathCR rate going to be? Shilpa, guess for me.
65%.
65%.
Agreed.
65%.
70.
70%.
With all the caveats we discussed before, between 50 and 60%.
So we're going to go a median of 60%. I'm up for 65. I'm going for 65 too. There's where I am. There we go. Okay, if it is 65%, then patients going to come to clinic. They're going to say, I just looked at the publication. I've got them. I'm on the same drugs. There's a 2/3 chance that I've got no cancer left. I don't want my bladder removed. I think 90% of patients are going to do that. And I'm going to find it very hard not to tell my patients that, by the way, you're just about to have the biggest operation you can imagine, and there's a 66% chance that you don't need it. So the question is, how important is this trial here, looking at bladder-sparing approaches, and what was the issue going on with local recurrence of disease? Who would like to answer that question? Carla, would you like to?
I'm happy to answer that. Yeah, I mean, I think this is an important trial. That's the first point. The second thing is patients who had a clinical complete response, the majority of them opted to keep their bladder, not surprising there at all. And I think it's cool because a number of patients got adjuvant nivolumab, also really important. But what I feel with this trial and the retained study that was presented before it, we are still seeing a fairly high rate of recurrences within the bladder, and some of those are developing into metastatic disease. So I personally don't think doing nothing to the bladder is okay right now. I think we still need to consider trimodality therapy. Now, this could change with something like EV Pembro for
Or
truly seeing...
intravesical TAR agent.
Sure, yeah. I think that
That's where I think it comes in.
If we're seeing...
I think it's about local
Well, that's
control.
what I just said.
I think
I know.
And
Yeah.
I said that too.
Yeah, and I think that'll be the comparison, looking between something like TAR 200 and maybe TMT.
Okay, we've got a minute and a half left or so. This is a slide again. I wrote this a little while ago.
We have 5 minutes according
5
to
minutes.
trial.
Yeah, I'm going to try and have a 2-minute break between the two. So this is curing most patients with muscle-invasive bladder cancer without surgery. This is aspirational. So T2 to T4, N1 disease at the beginning, systemic therapy, discussion about ctDNA at the beginning. Either you do exceptionally well. We think 70% of patients are going to be in the green box. They're going to go observation, maintenance, immune therapy for a year. I think that's probably right. But that question needs to be answered, coming back to what Tony said previously. Do you need to have the adjuvant period as well? And then you've got this yellow period in the middle where some of the results look good, but it's not completely cleared. And then there's an issue about radiotherapy. Then there's the losers. I think there will be those losers, I'm afraid. And we do surgery on them. And if they remain ctDNA positive, I don't think we should be giving more of the same drugs. I think, if you've given chemotherapy, EV Pembro or Durvalumab neoadjuvantly, you've had surgery, you're positive, more of the same probably isn't going to, you should be maybe switching to something else.
But Tom, to your point, if they are ctDNA positive or cystopositive despite the systemic therapy, then why would we make them go through a big surgery? Probably switch to another systemic therapy.
So even then they're not getting surgery? I mean, that's
it
quite
says
radical.
surgery there, right?
Sure, yeah.
They shouldn't be getting surgery.
So Petros, Andrea, far away. What do you think about that slide? Is it insane?
It's very busy.
Yes.
But I'm following what you're saying.
Yes, this is unusual.
Systemic therapy and, assess their ctDNA and then do something local and keep the bladder. I mean, I think that is what we should be doing for our patients. This is what patients want. They want to keep their bladder. And if it's really up to us to design the right trials so we can do this.
And I think in the last red box also TAR 200 plays a role.
In the red box too. Carla, what do you think about this slide?
Yeah, I like this slide. I think in the green box, I would like to see sort of a randomization between TAR 200 and concurrent chemoradiation.
And Petros, what would you do differently other than all of it?
I think the points are all well taken. The challenge is feasibility and accrual in this study. These are the trials we need to do.
Well, these are like 5 studies. Right?
Yeah, these 5 studies, of course, at least, right? Maybe more than that. But I like the colors, by the way. So I think that the first question we have, Tom and team, is how can we stringently define clinical complete response and correlate that endpoint with long-term survival is that good surrogate? And I think we're getting some hints about this data. I think your approach is reasonable. I don't think we really know, to Shilpa's point, if you have ctDNA positive disease, is that systemic disease, micromets, do you want to change systemic therapy, or should we go locally? That's a question, and I think it depends also on what other systemic therapies we may develop down the road. Maybe more ADCs. Maybe we can have better biomarkers to piece that apart. By the way, the urine DNA is very promising, but it's not there yet for clinical utility. We need more data with urine DNA.
Okay, so we've got a couple of audience questions coming up in the last minute. Can we fire away with this first question? Is there a QR code that people can link to? Do I need to move it forwards?
Laurence, you can vote for me too.
Here we go.
We can vote too.
I don't see why we shouldn't vote. Have a go. See how we get on. I'm going to vote.
Me too.
We can vote. I voted at ESMO in this discussion.
For your own discussions.
But Tom, I'm going to ask you this. What about dose-dense-vac IO? We need to talk about that.
Well, there is going to be a dose-dense-vac durvalumab phase 3 trial. Okay, can we close that one? Because we've got 1 minute left for our last question.
One more.
Okay, can we move to the next question? Is that possible? Okay, so would you give EV Pembro for a patient whose cancer's progressed? So let's say you're giving durvalumab is the standard of care and your patient progresses. Would you give EV Pembro afterwards? Yes to all patients. Yes, but a 6-month gap since durvalumab, or yes, a 12-month gap. Pardon?
How about no?
Yes, or yes.
Okay. There's a flaw in the question. Look, if you think, should we re-ask it? Is it probably too late to do that?
Maybe people can raise their hands who would never do it.
Yeah, what about no? Are there
no?
no's? Or should we re-ask the question after the break, Brian? With a no in it? Yes, we're going to do that.
You can
Brian's
ask
going to be in
EV
charge.
Pembro or just EV.
I quite like the question, but there does need to be a no. Yeah, I think it's a fair point. You know, on that, bombshell,
there's mics at the end of the room.
we've got 2 minutes left for the live stream.
You're doing good on time, Tom.
I've never seen Tom be on time.
Ahead of time.
We have a question which is fabulous.
Is this my vote?
Dr. Campbell.
I'm very enthusiastic with the data. I still, what haunts me in my clinic are the patients dying with metastatic disease, bladder intact, bleeding, infected, fistula. That's still a major problem that we face. And I think we can get some insight for the EV Pembro patients, and maybe this is something we can look at in night. For the patients that have metastatic disease, bladder intact, how are they doing in the long term in terms of their bladder control?
That's a great question.
Patients end up
Very
progressing,
symptomatic.
and we have to figure out what to do for those patients, whether it's radiate, whether it's TAR, whether it's palliative cystectomy in a subset. So that's a population that we still have to figure out.
I have often found that if the systemic therapy is working, that usually does help the local control. Not always, but it usually does. But in some cases, some patients do get in trouble, and we need better treatments for local control.
So more support to my wish list, Tom, to capture those patients in Niagara and report the data in the future.
We're going to round this up. Thank you for the question. We're a minute ahead on time. Thank you to the panel, and thank you to the audience for your questions. Thank you.
Thank you, Tom.